Thank you, Alice, and thank you too for having me here, and giving me the opportunity to present part of my research and the work I've done in the last few years. I was not aware of the introduction that you would have delivered on my behalf, Alice. Thank you very much. So I just prepared a 1-minute slide on who I am and where I'm from. So I'm from Bologna, which is in northeast Italy. Bologna is famous for having the oldest university in the world, established in 1048. It's also famous for having the largest mileage of covered arcade path in the city. So even in a rainy day, you might as well walking around the city center and enjoy the beautiful shopping without getting wet, and is also famous for the Bolognese sauce. So I did my undergraduate in medical imaging sciences there, and then I moved over to the University College Dublin in Ireland, where I completed my PhD, and my PhD was part of a larger multi-center study called BioVasc under the supervision of Professor Peter Kelly, who is a consultant neurologist. So as part of this study, we were able to scan and follow, scan with PET and MRI, PET CT and MRI, the carotids of over 100 patients, and follow them for 365 days to identify recurrent events after the onset of a stroke or a transient ischemic attack, and see whether we could find an association between a high signal identified on positron emission tomography imaging and recurrent events in the period that we followed the patient for over a year. I moved then to the University of Sydney in November 2020. COVID did complicate things a bit, but I eventually managed to move over, and I'm now a faculty lecturer at the Medical Imaging Sciences, Faculty of Medicine and Health, and I'm a member and the early career researcher of the Sydney Clinical Imaging Network. So atherosclerosis is the main pathophysiological process underlying most of the vascular diseases, including cardiovascular diseases, heart attack, stroke, or transient ischemic attack, and peripheral vessel disease. Despite improvements in better patient education, better lifestyle, having access to better food, better treatment options, and better drugs. As we can see from the diagram from the World Health Organization in 2019, we can see that ischemic heart disease are still the leading cause of death globally. So a lot of work must be done to prevent these deaths. So really, despite targeting the known modifiable risk factors such as quit smoking, improving diet, although we have seen some progress in that, and despite optimal medical care, the risk of cardiovascular events and stroke remains high. According to a publication of the World Health Organization, Cardiovascular Diseases in 2021, nearly 18 million people died from cardiovascular disease, and out of this death, 85% were due to heart attack and stroke. And some predictions are talking about, some predictions are saying that approximately 23 to 25 million people are predicted to die from CVD annually by the year 2030, which is not which is not too far from now. So a lot of work must be done to improve this scenario. Differently from 20, 30 years ago, atherosclerosis cannot now be considered as a bland lipid storage disease, and evidence showed that inflammation has a primary role in mediating all stages of atherosclerosis, from initiation to progress and eventually to the thrombotic complication that might cause cardiovascular disease or ischemic transient attack and stroke. Therefore, from an imaging and non-invasive point of view, there is an emerging and urgent need to identify newer mechanistic and diagnostic biomarkers into atherosclerosis disease that might help us developing newer and better patient risk stratification strategies. On the right-hand side of the slide, you can see from where we went and we are now. This is an example of a digital subtraction angiography image of the right coronary artery showing multiple stenosis across the length of the vessel. To where we can go, but obviously this is just a pure morphological assessment of the vessel, of the plaque within the vessel, to where we can go with advancement in technology. And this is a co-register image between CT, which provides the morphological information of the exam, with the corresponding positron emission tomography dataset, which provides, as we will see later, newer insights into the inflammatory activity or metabolic activity of an atherosclerotic plaque. Since imaging modalities were, in addition to the conventional digital subtraction angiography, were brought into the field of atherosclerosis imaging, a number of classification systems have been developed. I like to present this one, which was developed 20 years ago. So really when groups of researchers started to investigate using MRI dataset, plaque composition and the relationship between certain components identified within atherosclerotic plaque and prediction of, for example, stroke events. So they modified the conventional American Heart Association classification, and really from an imaging point of view, you don't really see much until you get to type 3 plaque. So the first few phases of plaque development are kind of missed using current imaging modalities. This is because of the limited spatial resolution and a number of other factors. Before moving to the next slide, I also want to introduce you to the concept, you might be familiar with that already, but to the concept of vulnerable plaque, or plaque vulnerability. Also known as plaque instability. So a vulnerable plaque is really a plaque presenting certain components and with a higher likelihood of causing thrombotic or cerebrovascular or cardiovascular events compared to other plaques that are seen to be more stable. So from a morphological point of view, plaque presenting a large lipid pool or intraplaque hemorrhage, areas of hypoxia as well, and a rather thin or rupture fibrotic cap are considered to be at a higher risk, and they have a higher likelihood to cause thrombotic and cerebrovascular or cardiovascular events. So in the last 20 years, we really moved from this kind of morphological approach to discovery and investigating newer or novel imaging biomarkers that might add the details and information to the risk stratification process of high-risk patients, or patients presenting with high risk with plaque presenting high-risk features. Some of the new advancements have looked into the changes, so Ansfield unit or attenuation changes of the adipose tissue or fat covering the coronary arteries of the heart, because inflammation of certain atherosclerotic plaque, the ones that we defined as vulnerable, might drive changes in the fat that cover them. So this is like kind of a new area of research. Also from an MRI point of view, where plaque components could be morphologically segmented, identified, and quantified. We can also add a metabolic component by using a corresponding positron emission tomography data set. So in this case, the patient would have undergone both MRI and PET imaging, and the two data sets are then fused. And although the sample size used for this study is rather limited, we could see a trend or association between increased signal, so increased metabolic activity identified on the plaque, and the presence of certain components within the plaque. For example, a larger lipid pool might be has been seen to be associated with higher metabolic activity. On the right hand side, we can see an example of the left coronary showing an area of high radiotracer uptake using positron emission tomography in correspondence of a soft or vulnerable, if you want, plaque. So in the next 10 minutes, we are going to look into the potential of computed tomography, magnetic resonance imaging, and positron emission tomography in the settings of atherosclerotic plaque assessment. Computer tomography angiography is increasingly used as the preferred non-invasive test for investigating symptomatic patients with suspected vascular atherosclerotic disease in clinical practice. Compared to DSA, so digital subtraction angiography, this imaging modality does not require the insertion of catheter within the cath lab or in the interventional radiology suites. So with several articles or a number of papers have been published in the last 15-20 years about the potential of CTA to identify plaque features associated with increased vulnerability. But really, after some literature review, I want to point out to these three studies here, the Scott Hart, which identify the presence of high-risk plaque biomarkers such as positive remodeling and low attenuation on CTA. It can identify patients with a 3 to 5-fold increase in their risk of myocardial infarct. The study in 2020, the CTCA data, so the CTA data sets allow assessment of areas of changes of in fact adjacent to vulnerable plaque. And also Kaiser in 2022, so this year, demonstrated a rapid progression in the coronary low attenuation plaque compared to plaque that might show different imaging features. So really, if we look at the bottom, the bottom of the slide, we can see here on the left-hand side that CTA, so CT angiography after injection of contrast, is able to quantify the plaque volume, and within that plaque volume, the different components based on attenuation ranges that have been previously validated with histology. Spatial resolution of CT is good, but it's still a limitation, particularly when looking at smaller atherosclerotic lesions. Imaging artifacts caused by the nature of the image, of the X-ray image formation itself, represents another limitation that we must be aware of. And also, it's that in order to produce and generate CT images, we need ionizing radiation, and therefore we need to deliver a certain amount of those to patients. in terms of potential and future development of CTA, not even a year ago, less than a year ago, has been presented a new generation or a new family of CT scanner known as photon counting CT scanners. So really, these photon counting CT scanners, they have they are based on a new detecting technology for photons. Very briefly, with conventional CT, we currently transform the energy from the photons into light and then into image, whereas with photon counting CT, we don't need that intermediate passage, and therefore we are able to generate images with higher spatial resolution. We might enable the testing of new contrast agents, and therefore we can, and also reduce the dose to generate such images. This is something we do here in Sydney. So we recently explanted some. We recently taken some coronaries from explanted heart in patients undergoing heart transplant, and we are trying to recreate. We are trying to recreate the imaging condition by inflating a balloon within the coronary, within the explanted coronary with contrast agent, and imaging it ex vivo to really run a comparison imaging histology and identify new biomarkers. Positron emission tomography has a good potential for identification and risk stratification of unstable atherosclerotic plaque. So differently from MRI and CT, we can really image the metabolic processes occurring within an atherosclerotic plaque. And a few radiopharmaceuticals have been used and are being used from a research point of view in atherosclerotic plaque characterization. The parameters to consider when running a PET imaging assessment for atherosclerotic plaque is, first of all, the injected dose. So PET is most of the time performed along with the CT, and the total dose, effective dose for the exam is around 12 to 20 millisievert. If you want to run a comparison, a chest X-ray is 0.1 millisievert, and the dose, the radiation dose that we absorb by daily life, by walking into a place, by eating food, is 3 to 5 millisievert per year. So it's a high dose investigation. There are other metrics and technical features that have to be considered, but really PET might have the potential to provide information on the inflammatory status of selected atherosclerotic plaque and improve risk stratification of patients. It can also be used as a surrogate endpoint in the intervention studies to monitor the efficacy of a certain of a particular drug. 18-FDG is the most common radiotracer used, and so far it has been used mostly in the oncology settings, but it has also been seen to accumulate in cells with high glucose metabolism, such as tumors and the area of inflammation, so probably in the vulnerable plaque. This image here comes from one of the study where I worked as part of my PhD, so the BioVas study, and we can see areas of increased radiotracer uptake corresponding to plaque within the carotid bifurcation. With PET imaging, we have several limitations, including spatial resolution, which is not optimal for atherosclerosis imaging. When using FDG as a radiotracer, the uptake by the myocardium is significant and might mask uptake within the coronaries, and also cardiac and respiratory motion. They need more work in terms of engineering work to reduce the motion of the, to reduce the artifacts or the issues on the images related to the motion of the chest and the beating of the heart. Another radio tracer that can be used is 18F-NAF, or sodium fluorine, which was originally developed as a radio tracer for bone metastasis, but in vascular imaging is able to identify areas of plaque microcalcification that might be undetected on CT and that have been correlated with higher likelihood of having vascular events. The same for the 68 gallium dotatate, which is a rather new application of a radio tracer used for purposes other than atherosclerosis so far, and it can identify areas of it can identify large lipid pool areas within atherosclerotic plaque. PET imaging has a number of limitations in atherosclerosis assessment, but with the newer advancement in PET imaging, we are moving now, we are kind of changing the technology, the PET technology, from a single ring PET to a total body PET. This will offer increased sensitivity, reduce the scan time. It will enable, it might give us the possibility to run multi-tracer studies, so using different radio tracers, and it will also allow us to reduce the dose significantly, as well as the scan time to generate an image. Magnetic resonance imaging is not really used for in the coronary district, but rather applied to larger vessels, such as carotids and femoral arteries. MRI can characterize plaque component, showing good correlation with corresponding histology, and a number of studies have been published comparing the imaging findings of carotids and corresponding carotid specimens after carotid endarterectomy. However, the limited availability of MRI in most of the centers and technical challenges, which include the spatial resolution, cardiac, and chest motion, they have kind of limited so far the application of MRI in coronary atherosclerosis. That's why it's used in the large vessel. So really, to sum up and conclude, advanced imaging techniques can interrogate selected biological and functional characteristics of atherosclerotic plaque that might provide novel mechanistic and diagnostic insights into atherosclerosis to improve the risk stratification of patients and identify what patients are at higher risk of developing a stroke or TIA or cardiac event, applied to the drug development aspect, the reduced sample size requirements and cost for phase 3 clinical endpoint studies, and increase the probability of success for drugs progressing to phase 3. So, maybe it should be also phase 2. So really, with imaging modalities, you can monitor the efficacy of a certain drug tested on a smaller sample of population. And imaging biomarkers of high-risk plaque could be used as relevant surrogate endpoints for phase 2 studies, monitoring the participants' response to a drug in a serial measurement. Thank you.
Thank you, Nicola. That was a really fascinating overview, and particularly for someone like myself who, before this presentation knew nothing about imaging of atherosclerosis. So do we have any questions from the audience? Because I have one. I know, particularly the MRI one, some of those, they looked like almost like an image of the moon with little craters on it. It was quite fascinating. So just thinking, I guess as someone who's not involved in the clinical care of people with heart disease, what could you comment on the accessibility of some of these machines? They look like quite large and fancy. Are they the type of thing that we're going to see in a cardiologist office, or is it in very specialist tertiary level centers?
So that's a good question, Alice. Thanks for the question. So to answer your question, conventional CT is widely available in most of the public and private centers. But obviously the new photon counting CT scanner that was just released not even less than a year ago, that one, I don't think there's any photon counting CT scanner available in Australia at the moment. In terms of PET imaging, that the PET would have a quite limited accessibility, and I'm sure it's available in large private clinic or large public hospitals. It's normally used in the oncology settings, PET. So in atherosclerosis imaging is a rather new application. The total body PET imaging is a completely new technology that is coming out now. So there is a limited number of systems installed worldwide, with two main vendors, with two main players on the current market. One in Asia, the other one in Europe. In terms of MRI, so to run this type of assessment, the MRI field that you need is anything above 1.5 Tesla. So you would not be able to perform such investigation using a low magnetic field scanner that you might find in small private orthopedic clinics where they're looking at extremities. So yes, you need like solid hardware and technological support to run these studies.
Yeah, well, hopefully more as the research comes out about how useful they are, they'll be more accessible.
Yeah, and most of them, they require injection of a radio tracer or contrast agent, so medical supervision is required.
Yeah. So we do just have another question. So would you be able to suggest which of these techniques could be used as a screening tool in the future to identify people with a high risk of a potential cardiac event?
Yeah, so Sally, that's a good question. And I've been suggested to use the word screening very careful. So CTA, as I showed before during the presentation, has been demonstrated to be an excellent diagnostic tool to identify a higher risk to identify high risk patients with the Scott Hart study. I would say maybe all of them have the potential to be used in the future to identify high-risk patients, but it goes back to what Alice was saying about accessibility and availability of these scanners.
Great.
So probably the easiest to use and the most available one is CT at the moment.
Great.
Thanks, Nicola.
Thanks, Nicola. All right, so thanks again. We'll go move on to our second speaker of the day, Nguyen, and he'll be talking about age-related variation in the provision of primary care services and medication prescriptions for patients with cardiovascular disease.
So thanks, Alice, and to organize the seminar this month. So it's my great honor to present a study in the CVRN Rising Stars seminar this month. So the title of my presentation today is Age and Gender-Related Variation in the Provision of Primary Care Services and Medication Prescriptions for Patients with Cardiovascular Disease. So cardiovascular disease is a leading cause of mortality and morbidity globally, which challenges the Australian health systems. To achieve the optimal management of cardiovascular risk and reduce the burden, WHO recommends to implement secondary prevention of CVD in primary care. Effective secondary prevention strategies for CVD includes the management, monitoring, and treatment targets of risk factors, appropriate treatments with multiple evidence-based cardiovascular medications, and timely receipt of chronic care services in primary care. Providing an equitable care through the Medicare is also an objective of the Australian health systems, regardless their gender and age. As population aging progress, demands on the existing primary care service will be increased and require more knowledge about utilization of primary care service across varying age groups and gender. However, there have been limited studies in Australia that examined whether usage of primary care service and prescribed medications vary by age or gender. So in Australia, the Medicare is used to ensure patients to have access to appropriate primary care service and medications. The Medicare comprised two essential elements, which was the MBS and the PBS. The MBS included chronic disease management plans, CDMP items, and also the GP mental health care items. The CDMP items provide rebates for general practice management plans to foster systematic care planning. And the second sub-items of CDMP is the coordination of team care arrangements, TCAs, which is to improve the multidisciplinary team-based integrated care. The third sub-item of CDMP is the review of the GPMP and the TCAs, which is to support the continuity of the patient care. And similarly, the GP mental health care items included the preparation of a GP mental health treatment plan, review of a GP mental health treatment plan, and the GP mental health treatment consultation. Under the PBS, the government subsidized the cost of evidence-based cardiovascular medications, including the blood pressure lowering medications, lipid lowering medications, and antiplatelet medications. So research evidence has demonstrated that the MBS and the PBS health service and medications are associated with reduced cardiovascular hospitalization and mortality. And in today's presentation, I will present the age and gender difference in the provision of these Medicare subsidized items. To address a research gap, the study aims to identify the age and gender-related difference in provision of chronic disease management plans, mental health care plans, and the prescriptions of guideline-indicated medications among patients with CVD in primary care practice. A retrospective cross-sectional study was conducted using the baseline data of the QUEER study. And we have received the ethics approval from the New South Wales Cancer Institute Population and Health Service Research Ethics Committee. Waiver of participant consent has been granted for this baseline data analysis because of the characteristics of the automatic extraction of the identified data from the health system. And the right paper of this slide is the protocol of our QUEER study. So if you are interested in this study, you can have a look at this the protocol of this QUEER study. So I'm going to briefly introduce the QUEER study. So QUEER study is a NHMRC funded cluster randomized control trial. So we have recruited 52 primary care practice and randomly assigned this 52 primary care practice into the intervention group and the control groups. And in the intervention group, the practice participated in a 12 months CVD quality improvement program to improve the secondary prevention at the primary care practice settings. And so far, we have completed the baseline data collection, 12 months data collection, and 24 months data collection. But in today's presentation, I will only present the result of the baseline data analysis. The primary care practice were eligible if they were located in Australia, managing more than 100 patients with CVD every year, and install the compatible data extraction software. The inclusion criteria for patients of the QUEER study were those aged older than 18 years, had documented diagnosis of CVD as recorded by their general practitioner, and the patient must have visited the participating practice more than 3 times in the last 2 years. So our baseline data were automatically extracted by an external health analysis and reporting platform named PanCS. We have extracted the de-identified data between 2018 and 2019 from all the 52 participating primary care practice. We have also collect a range of demographic and clinical de-identified data, which included the age, gender, indigenous status, CVD risk factors, mental health diagnosis, prescribed medications, MBS items, guideline-indicated cardiovascular medications, and the influenza vaccination. The primary outcome of this study was the uptake of the chronic disease management plans by patients with CVD. The second outcomes also included the utilization of mental health claims among patients with CVD who had mental health disorder, and the other second outcomes included the provision of guideline-indicated cardiovascular medications and the influenza vaccination. To perform the statistical analysis, we have stratified the CVD patients into 4 age groups, which were the adults less than 65 years, youngest old patients between 65 to 74 years, middle old patients between 75 to 84 years old, and the oldest old patients who are older than 85 years old. So we have used the Cochrane Armitage trend test and the unival linear regression to test for the unival trend of patient characteristics and outcomes across the increasing age groups. And for adjusted analysis, we use the multivariable logistic regression model using the generalized estimating equation to account for the clustering effect of patient practice. And we have also included a number of independent variables in our model, these independent variables included age, gender, indigenous status, current smokers, alcohol drinker, type 2 diabetes, BMI, blood pressure, and total cholesterol. And all these statistical analyses were undertaken using SAS. So through the baseline data analysis, we have published 2 papers already, and the left paper of this slide reports the age-related difference in the provision of primary care service and medication prescriptions for patients with CVD, and the right paper reports the gender-related difference in the provision of primary care service and medication prescriptions. So this table presents the demographic and clinical characteristics of patients stratified by their age. And we have noted that a total of 14,602 patients with CVD were included in this study. And there were 61% male patients. The mean age of the patients was 62 years old. And in total, 21% patients with CVD had coexisting type 2 diabetes. And we also found that there was significant difference in the cardiovascular risk factors among these 4 age groups. Compared with those less than 65 years, patients older than 65 years were significantly less likely to be a current smoker, less likely to be an alcohol drinker, and also less likely to have type 2 diabetes. And the mean systolic and diastolic blood pressure of the total cohort were 132 and 49. respectively. So the table in this slide was the most important slide of my presentation today, because this table presents the age-related difference in the provision of primary care service and CVD medications. And through this table, we have identified three main findings. The first finding is the chronic disease management plans were underutilized, particularly for patients less than 65 years. As you can see from the table, the proportion of patients with CVD who received the GPMP, TCA, and the review of either GPMP or TCA were only 44%, 38%, and 35% respectively. And in particular, for the patient group less than 65 years, the proportion of receiving GPMP, TCA, and review was only 35%, 30%, and 20%, which were even lower than the other age groups. So this trend may be explained by the life expectancy theory, because in Australia, the average life expectancy was around 83 years. And as healthcare utilization often peaks at the end of life, it partly explained our finding that the highest proportion of using chronic disease management plans occurred in the 75 to 84 age group. And subsequently, slightly decreased in the age group of older than 85 years old. And also the relatively lower percentage of CDMP in the oldest old age group may be associated with the time and resource constraints, function decline, or fragility of older people, which impeded their ability to seek health care, or it may be associated with their the patient preference near the end of their life. So the second finding through this table is that we also identified the underutilization of mental health services, particularly for patients older than 85 years old. And we can see the red box here, only 3% patients received preparation of a GP mental health treatment plan, and only 1% patients received a review of a GP mental treatment plan. So these results may indicate a significant treatment gap. And the potential reasons explaining this shift in mental health service uses may include maybe because the oldest old pay people, they pay more attention to their physical health rather than their mental health, and they may possibly acknowledge their mental health disorders as a part of their normal aging process, or the other reason may include this oldest old group. They may have the perceived stigmas or fear the discrimination when they seek the mental health treatment, or they have a very low mental health literacy among this older population. And the third finding from this table is we also found that among the older patients aged higher than 65 years, the combination of blood pressure lowering medication, lipid lowering medications, and antiplatelet medication gradually reduced with their increasing age. So the reason for this, because probably the GPs, based on the safety consideration, the GPs and the patients, they may prefer the conservative treatments, which aligned with the philosophy of deprescribing. And the last finding through this table is it was not surprising to see the proportion receiving influenza vaccination increase with their age, because the people who are older than 65 years, they are eligible for the free influenza vaccination in Australia. And those people who are aged less than 65 years need a specific indication. So this positive findings was aligned with the recommendation of National Immunization Program. And we also conducted multiple adjusted odds ratio to confirm our findings. And after adjustment for the demographic and clinical factors, the difference in the proportion among the age groups receiving this primary care services and CVD medications remain significant. So this confirms with the findings that I reported in the last slide. These two tables reported the gender difference in the provision of primary care services and the CVD medications. And through these two tables, we found that women were more likely to receive CDMPs after the adjustment, but the women were less likely to receive the antiplatelet medications than men. And we also couldn't find any gender difference in the receipt of mental health care and other Medicare items. So this study has a couple of implications. The first implication is that this age and gender related difference found in our study may have implication for future secondary prevention strategies in primary care, targeting age and gender specific care needs. The second implication of this study is the observed difference by age of an opportunity to optimize CVD in primary care in all age groups to address the escalating CVD burden. And the last implication is the ongoing efforts are warranted to ensure improved uptake and the delivery of primary care service that are appropriately targeting those in most need. Like other studies, this study also have strengths and limitations. The strengths of this study is include a large sample size and it automatically extracted patient data, which ensure the reliability and the integrity of data and minimize the potential sampling bias and the inaccuracy of self-reported data. The study has also a couple of limitations. The first one is we couldn't extract all the social demographic data, such as we couldn't extract like education, duration of disease. So the confounding effects from other confounders may be existed in our study. The second limitation is each patient's clinical diagnosis was extracted from the electronic health records entered by the primary care providers. Therefore, the patient diagnosis may be not verified by the source documentation. The third limitation is the health services use may be underestimated because the absence of claiming these Medicare items does not reflect the care supports is not occurring. The fourth limitation was the overall use of medication is unclear. The extracted data were written prescription and did not include non-prescription or over-the-counter medications. The last limitation of the study is the study lacked information on the indication for prescriptions or reasons for not prescribing, such as contradiction or medication intolerance. And in summary, through this study, we found that the CDMP items were not commonly claimed by GPs treating patients with CVD, which indicated an overall underutilization of the CDMPs for patients with CVD, particularly for the younger cohort. And we also found that age and gender-related differences emerged in terms of utilization of chronic disease management plans, mental health care, cardiovascular medications, and influenza vaccinations in the primary care practice. And based on these findings, it's necessary to continue to optimize the mental health care among patients with CVD in the primary care settings through the identification, assessment, and treatment for mental health issues, and the integration of mental health into chronic disease treatment. So the next step of our studies will be like, we will need to conduct future research to understand the potential reasons for this age and gender-related differences. So the future studies would provide very important insights on how to inform current policy developments and facilitate the improvement of implementation of treatment options in primary care. So our study team would acknowledge the continuous support of all participating primary health network and the practice staff of the QUEER projects. So our collaborator partners include the primary health network, and we also appreciate the PNCS for their assistance with their data linkage and extractions. We acknowledge the funding support from Sanofi. We also would like to thank Tim for his assistance with the coding of data, and we would also extend our thanks to Caroline and Ken for their administrative support and legal arrangement, respectively. And in particular, I would like to thank our QUEER investigators, which include Professor Juliet, who supervised this project, and Dr. Nguyen, who made a great contribution to the status analysis, and Nashida, who has been leading the implementation of this project in the last 3 years. Yeah, I think that's all of my presentation today. Thank you.
Thank you, Chantu. Can you please stop sharing so that we can see if anyone have any questions? So I can start, Chan. So congratulations you and your team for this great work and for also the very high quality publications. My first question is, how did you define cardiovascular disease? Do you include like all types of cardiovascular disease, or just the major type like ischemic heart disease, heart failure, or stroke?
Yeah. The CVD, we have included all of these categories, as you mentioned, and also the CVD definition, including the coding based on their data extraction system installed in the primary care practice.
Yeah, thanks.
Yeah, and the main category of CVD is the coronary heart disease, heart failure, something. Yeah.
Yeah. And similar questions for the mental health disorders. What types of mental health disorder did you include in the definition?
The mental health disorders were defined by the data extraction systems. So
I've got a question. Thank you. That was really great. I was too busy trying to read your slide, results slide, and I missed what you said in terms of the gender differences. Was it men or women who were most likely to get the GP management plan?
Let me share my screen. Sorry.
Maybe while you're finding that, I can also ask. You can just tell me. You don't have to show me if you want.
Yeah. So based on the analysis of the gender difference, we found that women were more likely to receive CDMPs than men. But
women were more likely, did you say?
Yeah, women were more likely to receive CDMPs than the men, but women were less likely to receive the antiplatelet medications than men. So the reason behind this may be because the sample of this study, the mean age of women were older than men. So that's why the women were more likely to receive CDMPs, because based on the research, the utilization of CDMPs is increased by the increasing age. So that's why maybe the women were more likely to receive CDMPs compared with men. Yeah.
It's interesting because the I don't know if you've seen some of the 45 and up study data looking at utilization of chronic disease plans amongst people with diabetes, and they've found that having a chronic disease management plan wasn't associated with a reduction in risk of hospitalization, but the review of a chronic disease management plan was. So there's probably something about writing it, but then actually going back to the plan and reviewing it that has some sort of impact on people's patient care. So interesting that only 20% of people actually had it reviewed as well. So
yeah, thank you. Yeah, because this paper we provide clear evidence about the age and gender related difference in the utilization of these primary care services, but we still could not confirm the reasons to explain these differences. So we need to conduct a further research to understand the potential reasons. So the future research could be a quantitative interview to ask for the GP or the patients the reason why they have different levels of the utilization of these primary care services, something like that.
Yeah, no, it's good. I mean, they're so important. They're such important resources, and a lot of people in the health system, particularly patients, don't know about them, even though they've been around for about 15 years. So, we can't expect more funding for, preventative services and things like this if we're not actually even utilizing them to begin with. So yeah, really important research. So thank you very much.
Yeah,
I'm just looking at the time. I am just going to, if you want to stop your screen, I'm just going to.
Excuse me, Qiang, can you please continue to answer the question in the chat from Sally, Nguyen, Alice, Rafa, thanks.
Okay, yeah, so there's a, if you just stop share.
Let me have a look. Okay, yeah.
So Tu, do you want to read out the question and I'll just quickly share my
yeah. So Sally's question is the lower level of lipid lowering medications in people aged older than 85 years old a reflection of the needs of these drugs in this group, or the under prescription?
Yeah, that's a very good question.
Yeah.
We really found. Let me go back to my slides to have a look there.
I can have a quick comment on this. I know a lot of. I know many researchers are trying to do the prescribing. Study on the prescribing of statin in elderly people. So maybe we can invite some to present at our seminars in the future.
Yeah, because our project had only provided the evidence about this related difference, but we couldn't confirm the potential reasons regarding the reasons why this the difference occurred in our studies. So as I said, so the future quantitative study will be needed to understand why the older people, they have limited use of the lipid medications. So based on the literature reviews, some studies have found similar results. So their explanation was that the GPs tend to have maybe the GP and the patient prefer to consultative treatments for the older people. So they don't want to be risk and when they are at the end of their life. So